I think we probably should start because we have a very packed agenda. Welcome again. Okay, a typical meeting etiquette. We're going to ask that you're on mute so that we can get through the materials and everybody has a chance to listen. Well, as always, we want your comments and we want your questions in the chat. We're focused on a certain meeting agenda today, so we'll be taking questions that pertain to the agenda for the day. And certainly if we don't get to them, always send them into our email, or we will try to, certainly have the questions that were presented in the chat and get back to people. It is being recorded. It will be available on our website and YouTube channel, and closed captioning is available. Here's our agenda for today. We are really thrilled to be able to bring a couple speakers to you that advocate on the national level, and they can give us some perspective. We're going to then, I think you'll realize after we hear from the speakers that Maryland is really, we are not alone. We are not alone in this fight. We're not alone in what we're facing. We're going to go through the key components of the proposed waiver amendment, number 4. That's the purpose of this meeting. And we do not have our full comments, vetted at this point. We still have a few more days, right? We've got till the 29th or 28th. So, but we are going to talk about things to think about as you all formulate your comments, and things that we're thinking about as we formulate our SDAN comments. And then we will, of course, go to question and answer and discussion. Thanks. Next. First, I want to bring to you, and super excited to introduce Heather Sachs to you. She's a longtime friend of mine. She is the Policy and Advocacy Co-Director for the National Down Syndrome Congress, and she does a lot of work on the national level. So Heather's going to speak to us, and then she'll be followed by Molly Morris, who is the co-founder of the Self-Direction Center that's dedicated to strengthening self-direction through community building, education, and research nationwide. So she can give us more of a specific, through the lens of what's going on in self-direction across the country. So I'd like you to welcome Heather. She'll give us a few pointers.
Thanks so much, Patty. Hi, everyone. As Patty said, I'm Heather Sachs. I am with the National Down Syndrome Congress. We're a national organization serving individuals with Down syndrome, their families, professionals, and other allies. Do a ton of advocacy work in DC and on the state level as well. I am one of you. I am a parent, part of the Maryland disability community. I have an almost 21-year-old daughter with Down syndrome, so we are just about to enter this wonderful system we're all discussing. And I'm just here to give you sort of the national perspective on what is going on with Medicaid. I've found in talking with other parents and advocates that there's a lot of misconceptions, confusion surrounding, why different actions on the federal level impact Maryland, and sort of how the whole Medicaid financing structure works. So let's go to the next slide. And I'm going to talk initially about the state and federal partnership. So a lot of folks don't realize that Medicaid is funded by both the federal government and the states. It's a very, very complicated formula that is not worth discussing right now. But the federal government tends to fund about 50 to 75% of Medicaid services for each state. So that is a very significant number. So in a little bit, we'll talk about the massive cuts looming on the federal level, which obviously will directly impact the states, because if there's less federal funding coming, then states have to make up the gap. States, though, get to run their own Medicaid programs within certain federal rules, and those rules are dictated by the Center for Medicaid and Medicare Services, which CMS. Dr. Oz is the leader right now, which we will talk about CMS in a little bit. States can request waivers from CMS, and we talk a lot about waivers, and waivers have different names in different states, but ultimately, what is a waiver? Unfortunately, the federal government and very, very antiquated laws still on the books have a right to be institutionalized, essentially. So if need services, and, your family can't provide them, which in most cases is the case because of the exorbitant cost of services, the state and federal government must provide you Medicaid services in an institutional setting. And we could have a whole call about, what's wrong with that. And that clearly needs to change. But that's what the law is right now. And that's the way it stands. So states can request a waiver to waive out of this institutionalization right. Okay. And that's what our waivers are. And the waivers are for typically for what we call home and community-based services, HCBS. And I'll talk about that in a second as well. So the states request these waivers, and the federal government gets to set the rules, approve the waivers, not approve them, impose whatever conditions they need to on these waivers. And then the state can go and offer their home and community-based services programs. The states get to decide who delivers the services, meaning, traditional providers, families, vendors, etc., what optional benefits are offered, and we'll talk about that in a second. The states also get to decide the payment rates and program structure, although as we'll see, the federal government unfortunately has put a lot of limitations now on the state's ability to raise funds for this program. And the states really decide which services are offered. So when we talk about Medicaid services offered, and there's a huge page on Medicaid.gov about this, there are mandatory services that states must offer. All states receiving any type of federal Medicaid funding must offer, there's a bunch of, a list of designated mandatory services. And those are usually more in the healthcare bucket. So those are more things like transportation to doctor's appointments, prescription services, outpatient hospital services, labs and x-rays, etc. All states, in order to get Medicaid funding, must offer those services. Then you have optional benefits that states may offer. And we really see wide variations from state to state in this. For our community, I guess the most significant optional benefits that some states offer, some don't, are dental benefits, vision benefits, different diagnostic screenings and rehabilitative services like physical therapy, occupational therapy, speech therapy, inpatient psychiatric services, etc. You get the gist of that. This is very significant because when a state has only a limited amount of funding, Medicaid funding, that they're receiving from the federal government, in order to keep that funding, they must offer those mandatory services first. And then if there's anything left over, then they can offer some optional services. And we're seeing major changes in a lot of these optional services being offered. Unfortunately, what history has shown us, and in the past couple of years, there have been a bunch of studies that have come out and showed this, that when state budgets are crunched, as they are right now, Medicaid, home and community-based optional services are cut every single time. In all 50 states, there's data showing that in, the last decade or so, when there have been massive Medicaid cuts and restructures on the federal level, every single state has cut those optional services. And it's not always obvious when a cut is a cut, right? So sometimes it's changing the eligibility criteria. Sometimes it's changing the scope of the services. Sometimes it's changing the provider rates, as we all know, which will, further destabilize the workforce. But all the time, the states cut these optional services. And a lot of times it's because they don't have a choice, because they have to offer that mandatory bucket of Medicaid services first. You've also heard a lot about this whole budget neutrality and budget neutral. And there are people that are much more well-versed in the Maryland specifics than I am. So I am not going to get into numbers with you guys. But just know that at the federal level, we talked about the entitlement, the right to be institutionalized. So the federal government sort of has this amount of money that, certain people have figured out, and they can actually figure out the cost it would take to institutionalize each particular Medicaid recipient. In order to get the waiver and get funding, states have to show that providing services in the community is not going to exceed the cost of providing services in an institution. And that's what they mean by budget neutral. And obviously, there's a lot of debate as to how they come up with these figures. But when you hear budget neutral, that's what we're talking about, that the amount of money that a state spends to provide someone with Medicaid services in the community cannot exceed the amount of money that the state would spend to provide those services in an institution. Okay, let's go to the next slide. Okay, so you've probably heard a lot lately about CMS, the Center for Medicaid and Medicare Services. It's the federal agency which oversees Medicaid and Medicare. It's located within the Department of Health and Human Services. As I said, it approves state Medicaid plans and waivers. It issues regulations and guidance. It monitors compliance with federal law, and that is very, very significant because many times they will tie certain conditions to Medicaid funding. And remember, states are very, very dependent upon the federal government for about 50 to 75% of the Medicaid funding. So they really have to try to comply with those rules that CMS puts out. CMS also conducts audits and program integrity reviews, and they can require corrective action plans for things that states are, not doing correctly. We've seen that a lot in the past. We may see that again. But what I wanted to emphasize to you is that under this administration, we have never seen CMS going after the states like they are under this administration. They are being extremely aggressive in enforcement, and what they're doing is they're holding up a lot of funding for specific programs without even giving the states a chance to show that there's no, that the level of fraud in those programs is not what the federal government is accusing them. So typically it would be that, CMS, suspects something is amiss. They, require, send some nasty letters to states, require certain corrective actions. States have to take those and show that they're complying. But what we're seeing now is basically just based on, an assumption or guess, CMS is withholding funds from entire programs. And that really is obviously having a very negative impact on the people that the programs serve, as well as the providers. Let's go to the next slide. Okay, so many of you have probably heard the term One Big Beautiful Bill Act. I am not going to refer to it as that for the rest of this presentation because in my opinion, there's nothing beautiful about that bill for people with disabilities. It was also called HR 1, and it passed last July 4th and, was signed into law then. It is now currently in the implementation phase. This bill did not just make massive cuts to Medicaid, but it made major structural changes as to how Medicaid works. The most key provisions that you've probably heard of are what's called community engagement requirements or work requirements. And that means that starting January 1st, 2027, all 50 states are required to have a work requirement in place for certain Medicaid recipients. And when I say certain Medicaid recipients, I want to allay a lot of fears that are probably on this call. This work requirement really just applies to the Medicaid expansion population. So, most of our folks, probably most of the people on this call are receiving Medicaid services through the disability pathway. Folks on the disability pathway do not have to meet those work requirements. However, the entire system is still going to be impacted by these work requirements. There may be a lot of family members that need to meet these work requirements if the family is on Medicaid. And there also are a lot of direct support professionals who themselves are on Medicaid through the Medicaid expansion population, and they're going to have to meet these work requirements as well. And these work requirements mean that you have to prove to your state Medicaid agency that you are working 80 hours a month, either in a job or a volunteer position or in school, and file that paperwork every single month. And if something goes wrong, that is a justification for getting kicked off of Medicaid. So again, many of our folks will not have to actually meet those work requirements, but the whole system is going to continue to get jammed up, and even worse so because the state Medicaid system now has to accommodate for all of these additional filings. I just wanted to put out there that we saw that the state of Nebraska was an early mover, and they already imposed their whole work requirement system, and it is up and running as of May 1st. Another key provision of HR 1 was that instead of every 12 months renewing eligibility, again, for the Medicaid expansion population, they are now going to have to reprove their eligibility every 6 months. And so again, much more paperwork to file, much more instability to the actual recording system and the bureaucracy in general. And we all know that the state Medicaid agencies are very short-staffed as it is. And then there were new limits on state financing mechanisms as well that this bill put into place. For example, states cannot raise taxes on providers anymore in order to compensate for the gap. Let's go to the next slide. Okay, so as part of the bill, it said that CMS had to essentially finalize all of the rules leading to the work requirements, the re-eligibility determinations, everything else in HR 1 by June 1st, 2026. That is just in a few short weeks. CMS issued some guidance back in December, but nothing is finalized yet. And so what this means is states have literally been building the plane as they're flying it. So it's very, very frustrating and difficult. States have had to revamp their whole systems to make accommodations for a lot of these things, but they still don't understand yet what the rules are from the federal government. So they've really been having to guess at a lot. And I just wanted to mention something really quick about the archaic technology that a lot of these states have. A lot of states, I believe, including Maryland, actually, have technology that is decades old. I mean, I think Maryland's goes back to the 80s. And so in addition to having to build this whole system, there's a lot that they need to do with investments into new technology in order to account for these new filings of work requirements, et cetera. So the overall financial impact on Medicaid from HR 1 is that it is anticipated to reduce federal Medicaid spending by $911 billion over the next 10 years. And so again, when we're talking about a federal state partnership with these very significant reductions in the federal funds, states are left to make up the gap. And again, one of the first things, unfortunately, that they cut are those optional Medicaid services because they can't touch those mandatory services. And then just a quick thing about work requirements. The federal government is counting on the fact that a lot of people are going to lose their Medicaid because they can't comply with these work requirements. And so much so that they've done estimates and numbers on this. And so it's estimated that Medicaid federal funding is further going to be reduced by $326 billion, and that it's going to increase the number of uninsured people by 5.3 million. Let's go to the next slide. So what are states doing now? As I said, right now they're having to fly the plane while they're building it, right? So there's rapid implementation prep. So there's a lot of IT system overhauls that need to happen, staffing and eligibility workflows. They have given some federal grants and some vendor support to certain states, but obviously it's not enough. We're seeing budget impacts already showing up in states as they're finishing up their legislative sessions. States have been allocating millions of dollars to try to get these new administrative systems into place. So any money that they're putting into that, they're also taking away from home and community-based services. And we see that they're already making budget cuts around the country. And unfortunately, people with disabilities are feeling the brunt of that. Let's go to the next slide. So very recent HCBS impacts. I know Maryland just finished their legislative session. There's quite a few other states that either just finished their legislative sessions or are in the middle of them, but have successfully passed some legislation. I just listed on this slide some states that we have already seen have eliminated entire HCBS programs, reduced provider rates, made eligibility more restrictive. And so, as Patty said earlier, Maryland is not the only one that this is happening to. I did want to flag something in Georgia that just happened the other day that was just very, very disturbing. And that it's that there are, about 8,000 people on the waiver waiting list in Georgia. And by the way, the reason why there is what we call a waiting list is because those waivers are optional, because the states are not required to provide services outside of an institutional setting. If they were required to do that, there would not be any waiting lists. So Georgia has about 8,000 on their waiting list. Their state legislature funded 900 new waiver slots in their state budget, passed the budget. So, passed Democrats, Republicans, but then the governor actually vetoed certain aspects of the budget, line by line. And one of the lines that he did was he vetoed the funding for 800 of those 900 new waiver slots. So even though, the will of the people and their legislative body wanted to fund those 900 slots, only 100 new waiver slots will be funded in Georgia. So, again, we're seeing more and more states making cuts with more to come. Let's go to the next slide. Okay, so we've heard a lot about fraud, and fraud absolutely does exist. I'm not going to say there's no fraud in any system. Most of the time, fraud exists at the provider level. It does not exist at that, individual level of people being served by Medicaid, home and community-based services. Unfortunately, though, and fraud has always existed. This is not something new. States have been, trying to grapple with this and get a handle of it for many, many years. CMS for many years has tried to, come after certain states that have more fraud than others. But again, not as aggressively with locking up all funding for certain programs. Unfortunately, what we're seeing in today's, very polarizing day and age is that this is really being politicized and amplified. And people with disabilities are really, really stuck in a bad position here because we depend on these home and community-based services. So we're seeing, Congress get involved. They've had a bunch of hearings and called a bunch of states in. We're seeing increased audits, enforcement, very restrictive rules, outright holding funding. We saw that just yesterday in California. CMS withheld, millions and millions of dollars of California funding while it does a fraud investigation, instead of what they used to do, which was, provide some funding while investigating and then put them on notice and provide a corrective action plan. Let's go to the next slide. Why is this so bad for us that they're focusing on fraud, and particularly in the Medicaid home and community-based services space? First of all, it's easier for states to justify cuts. And I think we all heard that in Annapolis, right? Where a lot of the legislators just, kind of parroted talking points about fraud and abuse. Unfortunately, though, what we're seeing is with these new requirements that are being imposed by CMS, a lot of the burden is going to be put on the providers, whether you're a traditional provider or, a family care provider under self-directed. There's a lot more paperwork, again, that you're going to have to file to show that you're not defrauding the system and that you're using the money the way you should be using the money. What we're going to see is a lot of providers downsize and exit, and exit. And we all know that there's, horrible workforce shortage anyway for support folks, and it's just going to continue to get worse. People are going to have less choice and longer wait lists. Um, as I said too, we're going to start seeing enrollment pauses in certain states, service caps, and people are unfortunately starting to, in other states, even lose or not receive their services, even without any type of proven fraud. So we are going to see this burden shift to individuals essentially to prove their innocence rather than having the federal government prove their guilt. Let's go to the next slide. So the bottom line is just that, it's not just Maryland that's under this pressure. I'm certainly not justifying any cuts. I'm with you all in the frustrations that we have felt this, during this past legislative session. Unfortunately, it is only going to be worse next year because by January 1st, all of these additional HR1 changes kick in and all of the cuts kick in. So we're going to be back, in Annapolis advocating again next year. We are going to see, rising Medicaid costs to the states with less funding. As I said before, the system, an already unstable system is going to continue to be less stable. And states are going to be tightening, different requirements, increasing audits and paperwork, and really limiting spending. So that is what's going on nationally. And I just want to give a really quick shout out to SDAN for putting this together and for really doing such a great job in Annapolis this session. They've always been a very tempered voice. They stick to the facts, and they've been really great about explaining things to the broader community. So thank you, Patty, and the SDAN folks for representing our families so well.
Thank you, Heather. Like was clearly news nobody wanted to hear, and we're entering a very difficult season, a winter, if you will. But let's hear from again. We're very, very pleased and very lucky to have Molly and Molly Morris. If you'd like to come on, thank you.
Sure. Thank you, Patty. So I'm Molly Morris with the Self-Direction Center, which is a relatively new national nonprofit focused on advancing self-direction, but our organization is really built upon decades of national work around self-direction, including involvement with the cash and counseling demonstration and evaluation that took place in the 90s, early 2000s that really helped provide evidence base that self-direction is an effective model. It is a really rare and special thing in the social services world that we would get to do a randomized control trial. But self-direction is a model where there has been a randomized control trial that shows the effectiveness of this model. And so the work that we do nationally has really built out of that research over the years. And, the Self-Direction Center has been a long time in the making, particularly having a nonprofit that is serving self-direction nationally. And our focus is really one around building community across the country, particularly state by state. As we're talking about, Maryland is not alone in kind of fighting the good fight right now. And we are working towards building community to help bring advocates together that are facing similar challenges, as well as state administrators, FMS or financial management services providers, researchers who are all part of this ecosystem that really care about self-direction. It's really trying to bring those folks together, provide education about self-direction and how it works, including that there is a strong evidence base, and supporting additional research and supporting advocacy efforts nationally. We really believe that the center of this work needs to focus on people's lived experience self-directing. Self-direction is really a cross-disability model. So across the country, we see high degree of self-direction available for people with intellectual and developmental disabilities, but also physical disabilities, older adults. We continue to see more and more self-direction for people with serious mental illness. So this is a model that sometimes states use different language than you might hear in Maryland, but we're all talking about the same model that's supported by CMS that allows much more choice and control. And, a lot of what I had in mind to share really mirrors what Heather has covered. I think I'll just give a little bit of um, an angle on kind of what this has meant for self-direction so far. And in particular, one of the things that our organization does is every Friday we release a e-newsletter that's curating a list of the latest news articles on what is happening in self-direction across the country and also more broadly home and community-based services. So some of what I'm speaking to today is going to be kind of trends of what we're seeing from the news coverage and what we're hearing from partners across the country during what's really a challenging time, as Heather said. One, I'll just reiterate that Maryland is not alone in really grappling with these budget cuts. We've also, just as Heather said, been seeing in the news a lot of states reckoning with making budget cuts, and particularly advocates for self-direction programs are having to champion self-direction in the context of broader pressure across all home and community-based services. And sometimes how that manifests and what we've started to see more of is, I think that the scarcity in the budget can create some real tension between the traditional provider community and the self-direction model. And so sometimes we're hearing from organizations that represent traditional agencies making claims about self-direction that are not always accurate. And, I think that in a lot of our national advocacy, we really strive to work with the broader HCBS community and do work that raises all ships. But unfortunately, sometimes this pressure, we hear some of that just provider agencies feeling like to save my piece of the pie, we're really gonna criticize self-direction a little bit. And I just want to name that I think it's really important that in self-direction advocacy, that one thing we talk about at the center is that what matters at the end of the day is choice, and a healthy system will have self-direction. It will also have agency care. And I think it's really important that we seek as advocates to support HCBS overall, because these services, self-direction and agency services, are really important to people. I will also say that there's just been a huge impact on the growing concerns around fraud. Again, Heather mentioned this. I think we're seeing in the public discourse a lot of each week, a lot of coverage around the idea that home and community-based services in general are particularly vulnerable to fraud. There's, I think, a lot of what I find concerning is that this is not, the narrative doesn't necessarily reflect the facts. As Heather said, fraud certainly does exist. And I think everyone on this call cares about fraud not happening. And yet, I think that there's a lot of work we have to do to help make clear that there are many systems in place that help protect against fraud, and that those systems are quite robust and that rates of fraud are low. The narrative right now is very different from that. And historically, it is not new. And I'm sure all of you who have been involved in self-direction, you've heard people before have concerns that self-direction would be particularly at risk of fraud. So we are not unaccustomed to having to kind of explain what measures are in place to help protect self-direction against fraud, and to help give context about what would be the most meaningful way to continue to improve systems to protect against fraud, because it's not to remove self-direction, which is sometimes where people go when they are uninformed about the model. But what it is newer and different in the narrative is there really is an emerging narrative, particularly from conservative think tanks. Like you may have seen some coverage from groups like the Paragon Health Institute, really questioning home and community-based services and their program integrity in general. And some of the narrative that we're seeing is not just saying we need to tighten up, but questioning the idea of having a waiver to begin with. And there's language in some of these blog posts that get real coverage in the media around the idea of, language like, well, in institutions, we have better oversight than in community waivers, and real questioning of the validity of community-based services in general, and also real scrutiny around paying family caregivers. And again, there are robust systems in place, but there are major concerns that folks are raising about the idea in general of a family member being paid. Some of the misinformation we see being talked about, and you hear like Dr. Oz talking about this, is people getting paid for running an errand or going to the grocery store. And we know that actually the bar to get paid as a family member is much higher and represents really extraordinary care. So I will say one of the things that we are doing at the center to try and help respond to some of the misinformation and some of the real pressure and concern around fraud in home and community-based services is to really lead with the facts and help make more transparent what are all the systems in place in self-direction that help prevent against fraud. So later this summer, we will have a toolkit coming out that really in detail outlines all of the ways that self-direction programs prevent against fraud within financial management services, within information and assistance, within, state checks and balances, so that you as advocates, when you're in a position to help explain what systems are in place, you have a resource that you'd be able to reference to help give some of that information, because it's not always just because you're living in the program doesn't mean you're readily able to answer some of these questions. So we really want to get those facts out there about what systems are working. And then also, to really acknowledge that we all share the goal of preventing fraud. But if we are not being accurate in how we assess the problem, we won't use the right solution, right? So I think that we all know there are aspects of self-direction that could be strengthened, and these things can contribute to stronger program integrity. So for instance, in self-direction, information and assistance is one of the primary supports. In Maryland, you have support brokers. If there's not a strong component of a self-direction program where people who are self-directing are receiving education about their responsibilities, what's allowable, what's not allowable, that's going to lead to less program integrity, right? So we need to invest in systems that we know work and that are evidence-based for self-direction, as opposed to, I think some of the fervor can make the case for saying these programs shouldn't exist at all. And so I think we have a really important job to do to tell the story of the systems in place that do protect these programs. And, organizations like SDAN do such important work around gathering data about what's working well and collecting stories about the impact of self-direction. So I think that continues to be incredibly important as we face some of these, challenging narratives. And, as Heather said too, these systems are really complicated and confusing. And, I've definitely been spending some time talking to journalists who are trying to cover these stories, and they're trying to understand what this even means. And so we can really do important work to help educate how these systems work. And I just want to name how extraordinarily difficult these times are. But I also just want to acknowledge that having worked in this field for some time, we definitely have seen these cycles before for self-direction, where we've gone through cycles in the past where self-direction has kind of fallen under more scrutiny. Some of this has to do with changes in administration, people retiring who were involved in cash and counseling, who knew about the underpinnings of the model. But we have seen before some of this scrutiny, and then gone through other times where it comes back around, where there's a lot of enthusiasm and understanding for the model. I think coming out of the pandemic, self-direction was a really important home and community-based services strategy for states to serve people during the pandemic. And it really led to a big increase in self-direction, a resurgence of support. And we're, as Patty said, we're kind of entering a winter right now. And I think during this winter, we have to be prepared to help answer questions, give that data, and also be ready to help build again. Because I think inevitably in these cycles, when we see these cuts, we also see states then be able to come back and invest in these programs again. So I do see this as a time of preparing and coming together as a community. And I think that's something that SDAN does incredibly well, is bringing this community together. And at the center, we really want to help engage this community with the broader national community, and here to be a resource. So thank you all so much for coming together for this conversation. And I am grateful to get to hear from such a wonderful community.
Well, thank you very much, Molly. We really appreciate it. And we look to the Self-Direction Center often. And Molly's contact and the Self-Direction Center contact will be at the end of the PowerPoint if people want to sign up for that weekly newsletter. And thank you again, Heather. We really appreciate all the work you both are doing on the national level, because everything that comes down to the states starts up there. So we really, really do appreciate it. Alicia?
Thanks. Yes, it was incredibly powerful to hear from both of you, and really appreciate you being there. So that makes this slide kind of redundant, because the one thing I guess I do want to say is the state of Maryland last year made a fundamental shift and did change its mission statement. And you can see the difference between person-centered, family-oriented to high quality and healthcare. And so they were, that was a signal, I think, in terms of how things were maybe going to go in the future. And it also makes sense then that despite this tremendous advocacy efforts of all of you, of all of the advocacy groups, of all the individuals in both models, we were not successful at stopping significant changes in service and wages and rate cuts that are going to have a significant impact on the people using the service. The changes that are reflected in the final budget language of the Senate Bill 282, many of them require an amendment to the Community Pathways waiver. And so that's kind of brings us to the rest of our presentation today. The DDA proposed CPW waiver Amendment 4. And we will, kind of get started then on, how do we go? Where do we go from here? How did we get here? We know now. What's next? Athena?
Good afternoon, everyone. So the next step that we'd like to engage everyone in is understanding the proposed waiver amendment number 4 that impacts the impacts of that waiver amendment, and preparing to formulate comments and proceed to make those timely and impactful. So SDAN right now has sought clarification from DDA on some of the provisions of the waiver amendment. We may or may not get any written clarifications back from DDA during the comment period, but we have sought those, we have submitted those, and hopefully we'll be able to get some helpful clarifications to share. Continuing conversation with Disability Rights Maryland on a number of legal issues that we think are important to explore in the specific impact to participants with this waiver amendment. We will continue to support advocacy efforts looking into the cost neutrality concerns. And Heather and Molly mentioned that this earlier in the presentation about the cost neutrality being a comparison between the cost of self-direction and the cost of institutionalization. The next 2 bullets are really what we're focusing on in this meeting. From here, developing comments to the proposed amendment, talking about some how-to and by when, encouraging stakeholders to submit public comments detailing the impacts of changes as they impact your participant and those immediately supporting them. Encouraging participants and families to build positive relationships as you have in the past, and we encourage you to continue to do with legislators, helping them to understand participant needs and the impacts of these severe changes. So we'll move to Eldon.
Thank you, Athena. What we're going to talk about are the key self-directed changes in the waiver amendment proposal 4, which include 60/40 limits, self-directed funding methodology, change from vendors to individual providers, or elimination of unlicensed providers, changes in FMCS payments, and lack of day-to-day administration changes as per the SB 282. Back to you, Athena.
Thank you. So the first issue that we want to kind of take apart here a little bit is the 60/40, the rule that's being called the 60/40 staffing limits, and this relates to family as staff. The proposed change is, if this is exactly from the waiver, so many of you have already seen this language, but if a relative, guardian, or legally responsible person is paid to support one or more participants, they can work up to 40 hours per week total per participant. And this the 40 hours actually went into effect last year, but they can work up to 60 hours per week total across all people they support. That relates to the paid staff person. So if they are family and they are paid to a participant, then their maximum number of hours per week that that person can work and be paid across all participants is 60 hours. Each participant can receive a total of up to 60 hours per week from all relatives, guardians, legally responsible providers combined. So you have 2 family members supporting one participant. Each of those family members could work 40, but combined, they can only work a maximum of 60. So why we believe this is very concerning and why this matters is that it deviates from person-centeredness. Some participants have a number of family members serving them. Some don't have so many or any family members serving them. We feel that it erodes employer authority related to choice and control and flexibility, and destabilizes the current workforce, particularly where there are the staff that are available may be limited to family or significantly limited to family. Things to think about in formulating these waiver comments. For each participant, how does this impact or erode or impinge you or your participant's budget or employer authority? The 60/40 rules, we believe, must contain an exception for respite care by non-primary caregiving family members. The rule is that primary caregiving family members cannot, they must be a non-primary in order to provide respite, but the 60/40 rule will limit that in the way that we're describing right now. The 60/40 rules must contain an exception also, we believe, for short-term emergency situations that will arise. And there are other states who have effectively implemented these types of exceptions. So on to you, Jess, for the next slide.
All right, here we're going to talk about the self-directed funding methodology, which I think is something that is incredibly important and everyone should be paying attention to this. The proposed change is to create specific self-direction rates. And that is a huge deviation from what has happened in the past. Both models have consistently always used the LTSS rates in developing the PCP. What's being proposed now is to base these rates off of the Bureau of Labor Statistics as the base wage, which is not new. That has always been the case. And then to include employer-related expenses, which is a cost component referred to sometimes as ERE, and training and transportation, which is different than the LTSS rates that also include program support and general and administrative cost components. This matters because it will reduce rate and wage ranges by an average of 20 to 30%, with some ranges being as high as 50%. It creates a high-risk situation for sudden shifts in service coverage. The BLS code that is being used is not representative of the job. So there is a lot of advocacy that goes around surrounding this. The direct support professional occupation code does not exist yet. It has been talked about for a couple of years. There are bills at the federal level to introduce that as an occupational code. NADSP does excellent work trying to advocate for that. But in the meantime, we are left with a wage code that doesn't necessarily show the full spectrum of what a direct support professional does. And so it's a little concerning and it's misleading because we're basing, we're comparing apples to oranges. There have been no rate studies done on the costs of self-direction. And so in Maryland, the DDA uses the rate review advisory group, and they kind of instituted that years ago. This is the group of people or committee, like a committee that kind of advises DDA and their partners on the nuances of things that contribute to each cost component of a rate. And so that has always been the process, and they use data collection tools like the general ledger data collection tool to get information to inform them on how these rates are developed. And what we're seeing now is these rates are coming out without any information to inform them from the self-directing community. So there's a lot of things to think about when you're making your waiver comments. Most importantly, it's really important to suggest that these are the same services and in different settings, and it's a different model, but it's the same service. And that's, I think, really, really important to drive home. The costs of providing that service, while they may be very different as they are within provider models, it doesn't mean that they don't exist. And so that's really, really important to understand. I also think it's important for people to understand that if they're going to generate people's PCPs with these new rates, that is going to eliminate a lot of flexibilities for many people, which is the premise of the model, to be able to have choice and control and the flexibility to move things where you need it, when you need it. So I mean, I just think that that's a lot. That's a lot for people to absorb prior to developing their PCPs and understanding that now in their comments to DDA and to CMS. I don't know who goes next. Who goes next?
Thank you, Jess. Patty's up.
Okay, hi. So we have 103 people, and collectively we need to take a big deep breath because we've heard a lot of really hard stuff. We've heard that we were going to all have to kind of hunker down and figure out how we're going to get through this and how we're going to support the people we care about and support the people we love and our own selves. So we are going to continue advocacy efforts always, but just take a deep breath. So let's talk. I'm going to talk to you a little bit about the proposed change to change the language in the amendment. And if you've looked at it and you did the webinars, you know what the DDA is talking about here. As far as the actual waiver amendment, they're seeking to change the language from the word vendor to the word individual provider. But we know in policy change, that is a much bigger deal. And we know we're going to talk about here what a significant deal this really is and a significant impact this is to all of you. The other thing I want to say before I dive into that is that through these last 3 or 4 months, many of you have become extremely educated and have done deep dives into all of these issues. And we welcome any information you want to share with us, because we don't propose to be the authority on any of this. We just spend a lot of time. So if you've got information that we are not covering or you want to share with us, please bring it forward because you all have become incredibly educated over the last several months. And it is very obvious. Thank you very much for all that. Okay, so back to this policy change, we know the DDA has released a new policy stating that all unlicensed vendors would need to go through the DDA provider application and be approved by June 30th to continue services. I want to split that out a little bit. There are vendors for services such as nursing, support broker, CDS, personal supports. And then there are vendors for things that you access through IFDGS. Right now, we're going to talk about vendors for services. There has been no indication that there's any change to the vendors that we use through IFDGS because those are not providing services. You're purchasing activities, you're purchasing programs, things like that. So we're just going to focus this conversation on the vendors that are used for nursing, support services, support brokers, and behavior specialists. So we know that the DDA has a policy that nursing support services and support brokers need to be individual providers. Okay, that's instead of the word vendor. And those of us that are nurses and even behavior specialists, we knew this was coming a year ago. So we knew we had to be individual providers by this past January. And many of you know that because your nurses or would have given you their approval letter. They cannot continue to be paid after this past January. So this isn't new for the nurses. Support brokers have had to been approved and certified by the DDA. That's not new. And BSS has also had to be an individual provider. So you can check with the people that you as the participant or you as the family member that is assisting a participant. You can check to make sure that your nursing support services provider, your behavior support provider, and your support broker have all met the requirements. But here's where the big change is coming, and I know many of you know this, and many of you are telling us just how devastating this is going to be. But as of 7/1, July 1st, no unlicensed vendor will be able to provide services. And this could be your CDS provider, the participant's personal supports provider, respite provider. Those are services in the waiver: CDS, personal support, respite. And there are there are DDA licensed providers. There are unlicensed providers, great programs that have popped up to serve this need, and you've engaged them and hired them and paid them. And then of course you have individual employees that you hire to do that. So, and there's another category of provider that you may not be aware of, and we refer to them as the RSA licensed provider, residential services agency, and they often provide personal supports. And that could be something similar to the Elizabeth Cooney, is that it? Agency or nursing agency, right? Different nursing agencies. And they have a license, they're licensed under the Office of Healthcare Quality, and but they don't have a DDA license. So as of July 1, all of those providers are going to have to be licensed providers to continue to provide services. And we recognize there is a very short time period. So it is your job, the individual person with the disability who's the participant, or those of you that are helping that person to self-direct, to ensure that your vendor is aware of the changes and that they will be, you'll have the requirements met. Okay. We know that this turnaround time is almost impossible to meet that burden. Your CDS and personal support providers and respite providers that want to become DDA providers, we know that that application process is long, anywhere from 6, 8, 12 months to get through that process. We also know that the RSA providers already have significant requirements to get the license that they have. And then we know that there are many of the providers that you've been using that will elect not to do this at all because it's just too much of a requirement. It's too hard. It still leaves you with the ability to hire an employee for CDS or for personal supports. Now, what things to think about, And the things that we're talking about with the Waiver Advisory Subcommittee and other advocates is, and we're continuing to ask, even though the answer has been no up till now, we're asking the DDA to identify a bridge or a reciprocity that could happen between those RSA providers to become DDA providers, because they've already gone through a whole lot to become an RSA provider. So we're hoping that the DDA can and the MDH will figure out a way to make that easier for the RSA providers. There's other providers that you have that want to become DDA providers. We're asking, and we will continue to ask, even though the answer has been no, to design more of a fast track, a more efficient process, a pathway for those people who want to become DDA providers. I see that an RSA provider that stands for Residential Services Agency. They are often nursing agencies or staffing agencies, okay? And they have licenses with the state. They just don't have a DDA license necessarily. They might, but they might not. So we also are then asking the DDA just to hold off on this requirement altogether, delay it. We understand, as we heard from all the national folks, that everything's going to become tighter. We're not going to be able to fight back on the need for licensed providers, but we can advocate for the process to be fair and actually work for somebody. I don't know if that's going to happen. I don't know if we're going to make any headway, but that is the advocacy. So when you're thinking about your waiver comments, remember in the waiver amendment, it's simply a language change, but we know that it is much deeper than that. It is a policy change. Let your comments be on what is the change that's happening and how will it impact you as the person with a disability, and how will it impact the person, if you're the family members, how is it going to impact your family? We did a survey. We're going to show a little bit about that coming next. But we understand that this is a huge issue, and we invite any of you to give us more information if you have it. And we're going to share some survey results now.
Thanks. So we recognize that the language change is much more than a language change, as Patty said. We did a quick survey, and many of you probably responded to look at the implications of this to the participants. And this is, we're 45 days away from this happening. So it turns out that 90% of the people who responded to our survey, 90% of those people use a unlicensed vendor now. And to do things, 57% CDS, 32% personal supports. There's some respite ones and some day-to-day vendors. But these represent, at the minimum, 200 services hours per week that will be left unserved. And at this time of the survey, 90% of the people who responded had no transition plan in place on how to account for those hours, how to get the person who, by all accounts, from a PCP approval, assess needs, have the need for these service hours. So this is extremely, extremely troubling from the perspective of getting people what they need and getting the unlicensed providers to be able to become licensed. So DDA has made it clear that they can apply. They have the opportunity to apply, but as has been stated, we are hearing at least that it's a months-long, possibly year-long approval process. So we really are thinking there needs to be some kind of expeditious way to get in, or some kind of a transition period for people who are applying to become this. The findings we have seen here demonstrate that vendor services are deeply integrated into participant supports. And this abrupt service change without the planning, without the provider capacity or some kind of transitional supports will create significant instability. This is a very, very important thing for everyone who uses a vendor to kind of familiarize yourself with and make comments on We are hoping that by doing the survey and providing you with the survey results, you can use those details to support your comments. And again, I don't want to say all of this without saying it's horrible. It's upsetting to all of us at SDAN, but to every single participant who is running the risk of losing the supports that they need. And we do welcome others of your support in terms of new ideas. We're asking, but if you have other thoughts or other ideas, please do either put them in the chat, or if they're more personal, please send us an email. Because this appears on the surface as a language change, and that's how it looks in the waiver. But the language change turns into a huge, huge policy and supports change. So thanks for listening to my little survey rant. And we'll go on to the next one, which hopefully is less emotional. So in the waiver amendment, DDA has decided to change where the money for the monthly FMCS payment comes from. So back a decade ago, the money was paid just straight to the FMCSs. At the time, there were two. And then they made this change to put the fees in individual participants' budgets. So now the proposed change is the FMS fees will no longer be allocated through your budget, and instead will be considered an admin cost that's covered by the state, and you'll never see it. This is reverting, like I said, to how things were done in the past. It did not have negative implications at that time. And it is possible that for some people who had very, very tight budgets and could maybe afford only the FMCS with the lowest per month cost may benefit from actually having three to choose from. That's a possible upside. But we're unsure of other pieces of this, what the unintended consequences are, or the thinking behind it. And there's been limited information shared on how this could possibly affect the participant. So the question, I guess, to think about is, how could this impact a participant's choice on the FMCS option? So again, not nearly as an emotional change as the others, but feeling like maybe we don't have the whole story, or we do, and it's not a big deal. Don't know. So next we're on to Stephanie for something really important, day-to-day.
All right. So many of you know that day-to-day is a fairly new service. There was a lot of advocacy for years to see this go into effect, and we were all so excited because it really answers the sustainability question, right? We all know that self-direction for many individuals that are using it is the best model for them, but there's that question of how is it going to be sustained when the family members, parents, somebody close to them, it gets too old to assist them to do that job, or just isn't in their life anymore. There's a lot of administration that has to go on to make self-direction work and keep people safely in their homes. So day-to-day admin came about to kind of, really assist with all of those unanswered, right? All the things that paid staff or maybe family member couldn't provide would fall under day-to-day admin. So last year when they did the waiver amendment, they really drastically changed the role of day-to-day admin. And then you saw in the manual drastic changes to the scope of what the day-to-day admin can do. And we've all had some fun kind of laughing at that. I think our first snowstorm this year, there were lots of comments about, well, use your day-to-day admin. So we really advocated this whole year, in a lot of us and from all different groups, to try to restore the position, at least as much as possible. The scope really was my primary concern, was that scope has to be restored back to what it was intended. So we tried through the Waiver Advisory Council. There was a group that was meeting, with DDA. So we just, from all different angles, through the legislature. So we did get it back into the budget language. So the very first thing was that the new language in the budget says that the day-to-day administrator Support shall include non-direct supports that assist the individual with household management and scheduling, appointment scheduling, and money management tasks, such as reviewing and paying bills and assisting with the maintenance of benefits. That is in the budget language. That has been approved. There's nothing in the amendment that changes the role of day-to-day admin. It's still what it was as of the changes last July. So we believe we need to make public comment that they need to put in language that matches what's in the budget language. The current waiver states what it states now. It's the current waiver amendment on page 211 of the current waiver amendment doesn't align with that at all. So if you guys look that up, you'll see that. It's clearly stated in the waiver that day-to-day does not include making payments for household management care, budgeting any money management, developing staffing or cleaning schedules, or managing money and property management. We believe all of those things should be allowed according to the new language in the budget bill. So what needs to change? The day-to-day admin supports include direct and non-direct support not available under any other service, such as household management and scheduling, including assisting with staff scheduling and oversight. We don't feel that on the team there's really anyone else that can do that unless you have someone volunteering their time to do that, or many participants can do that themselves, but some can't, and that needs to be covered. Scheduling appointments, including medical visits, or personal money management, such as reviewing and paying of bills and assisting with the maintenance of benefits. We do agree that, as it states, that the day-to-day admin shouldn't be making decisions for the participant or approving and signing timesheets or vendor payments, that wouldn't fall under their scope. So this is an area where we feel that this impacts everyone that self-directs at some point. And we really need the community to make a public comment about this, add this to your public comments. And we don't feel that they are aligning with they're not aligning with what's in the budget bill. So that is all on day-to-day. Next we have Patty.
I think it's Eldon.
Oh,
Yeah,
Evelyn.
it's me. So next we're going to talk about the waiver amendment comment period. Before the proposed amendment can be submitted for approval by the Centers for Medicare and Medicaid Services, or CMS, there's a mandatory 30-day public comment period. The DDA will accept public comment from April 29th, 2026 to May 28th, 2026. Public comment can be submitted directly to wfb.dda@maryland.gov. We encourage you to share your thoughts, suggestions, and concerns as a member of the self-directed community. As SDAN formulates our organization's public comments, we would love to hear from you if you have any further feedback or commentary on these focus areas. Please reach out to us at self-directed advocacy network md@gmail.com. And Patty, I think you're next.
Stephanie? Or is this me?
Sorry, now we switched.
It's mine,
This
isn't
one
it?
is you. This one is you.
Okay, I got it. So as I told you in the very beginning, we have not formalized SDN comments because we still have until the 29th. We're formulating those, and we are wanting to share with you what CMS professionals and other nationwide advocates have shared with us. What makes an effective comment to a waiver amendment proposal? You are free to write whatever you want to DDA. We are not telling you what to write to DDA. We're just telling you like what we have been taught makes a good, effective comment in a response to a waiver amendment. These comments will be a part of the waiver amendment that is submitted to CMS. Everybody is encouraged to write to CMS directly if you want. But this is just an idea here. Formula for a comment could be stating the problem, why it matters to you as the participant or the family member who supports someone, or the staff person, or the other type of professional, and what is the ask? You stating the problem, i.e., the unlicensed vendor thing, And why does it matter to you? What is the effect going to be? And what do you want them to do differently? So again, identify the specific proposal or the section that you're commenting on. Explain the real world impact to the Medicaid waiver participant, because remember, this HCBS waiver is for the person with the disability who is the waiver participant. We offer a concrete recommendation or change. Example, the restriction of the proposed 60-40 staffing limitations will impact me or my loved one, and then you fill in the blanks with your real world story, your real life story. Remember that this is not a family support waiver. This is not a family caregiver waiver. This is a health and community-based services waiver for the individual to have the services for inclusion in their community and to increase independence and blah, 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 blah. So just, you know, as it pertains just to waiver comments, it would be to your best interest to limit your comments to what's in the waiver, how it's impacting, and what is the ask. Any other letters, comments, emails, whatever you want to do, you know, is great. And then SDAN, we hope to have our formal comments out. So and then a little before the deadline, and we will certainly share them. And the next one, I guess, is this now you, Stephanie?
Yeah. So as we said in the beginning, you know, despite all of the just amazing, tremendous advocacy efforts, we just weren't able to stop what's happening. We're not going to stop our efforts, right? We're going to keep on advocating, and they need to hear how this is impacting us. We were talking about this the other day, that, you know, the whole reason SDAN started in 2016 was the DDA was trying to dismantle family of staff. That's what started SDAN. So there's been a cycle. I think maybe Heather might have, somebody referred to that earlier. There's this constant cycle, and advocacy is, you know, it's always, you know, it's a forward, you know, an upward trajectory, but there's always a little bit of, you know, 2 steps forward, half step back. You know, this year I feel like we're, you know, making more steps backwards. You know, but we're gonna keep advocating, and it's staying together as a community and supporting one another through that and educating one another. That is really important. So we will continue to advocate for the protection of critical wage rates, participants retaining choice and control over hiring, including family of staff, and maintaining strong self-direction principles within the home and community-based service programs. A couple initiatives we didn't put on the slides, but some things that, you know, we have in the works. We've started a participant engagement group, and many of you have kind of signed up for that, and we in no way want to offend anyone, but what we're trying to create here is a platform for individuals with the disability. Most of us, I'm a parent of someone with a disability, I'm a support broker, right? We all are in this because we're passionate and we care, and no one's questioning that whatsoever. But this group, none of us, if you don't have the disability, you don't 100% know what it's like to live with that disability, right? We can be as close to it as possible, but we're not the one. So this group is for those individuals. Those of you that are on this call today, we want you. We want opportunity for you to feel like you have a platform where you can speak, and it's your room, it's your place. So we've got a wonderful board member, Sunny, that has kind of taken that up, and she's initiated that, and we've had a couple meetings that have just been very powerful. So we're starting that. That is Patty, correct me if I'm wrong, is that the first Monday of the month?
Yes.
First Monday of the month in the evening.
And those announcements go out from
and then the other thing we're starting, I think we're calling it Wine and Wisdom, and that is for other advocates, right, to come and join in. We're trying to figure out, like, we want to keep that small and intimate. So if we get a lot of people signed up, we might break off into multiple groups. We're figuring out those logistics, but we really want it to feel like it's a place where people can learn and build relationships. So we're figuring out the details of that. But, you know, we're trying to move forward in a way that people feel supported and encouraged, because we know we've got a long road ahead of us. So. Next slide. All right. So
Stephanie, did you also say where SDAN is represented in committees?
Yeah, so we have SDN reps on the Waiver Advisory Council, the rate review, our RAG, the rate review group, and then MIDSEC, which I can't even tell you what that abbreviation is for. So we do have representatives on all of those groups. We do our best to try to educate. I'm on the Waiver Advisory Council, and it has been honestly spent the first 6 to 9 months on that group explaining to others, and mostly providers, what about self-direction. They didn't understand how a budget was developed. They didn't understand basics about self-direction. In fact, most of the providers would tell me, well, we allow our folks to self-direct, right? That we're using the provider model. So trying to help them understand the true difference, and being an employer and what that looks like. So there's a lot of education that's taken place this year, and I feel there was a lot of animosity on the Waiver Advisory Council in the beginning, and we're all working together now. It's been really neat to see that, and I feel like we have providers advocating for us. I mean, they're all behind the day-to-day admin. When I started to explain that if you look at a provider model and you look at a group home, imagine running a group home without a team lead, without a program manager, without a house manager. How would you do that? They started to get it. They started to really understand, and they were the ones telling me, move forward with your proposal. And they all voted, positively in our last meeting. So, we want you to know that we're trying. We're really out there in all these avenues trying to advocate the best we can. So.
Thank you much. So that concludes our formal presentation of information to you. We're going to open up to the questions. We're going to bring those questions forward again as they relate to what the waiver amendment is. I'm going to take that first question because I just see something popped in, and then I'll turn it over to those folks that are going to bring the questions forward. But someone genuinely asked, and it's a really logical question. Would mentioning that fraud at the traditional level exists based on personal experience be a good point? And we would say no, because fraud exists everywhere in all government programs. So simply pointing out like they do it too, it's not an effective comment. If that's a criticism that you have and you want to lay that out to DDA, go for it. But as far as a waiver comment, I don't know that it is effective. How the proposed change, how it's going to impact you, and what you suggest is that the participant needs, right? So, we know fraud happens everywhere, as Molly and Heather let us know. We just simply, by pointing to the other model, does not get the point across that really will move CMS. One of the comments, and this is regarding the vendor, unlicensed vendor thing. I think you want to focus in on that. If that's an issue that's going to impact you, that your provider of CDS, personal support, or respite is no longer going to be available to you, you need to make that comment clear, because CMS is going to care that hundreds of people with disabilities in the state of Maryland will lose their provider of services, and the state can see it coming, and the state is not making a provision for it. That there are not enough quality providers, there's not enough people to hire, and so people will go without services. CMS will care that policy is in place with no transition period and when we can see it coming. So that's a very important comment to focus in on, as compared to being upset, it's not fair, put it out there. We're going to lose services. And even if my provider wants to do the application and become a DDA provider, the state has not allowed enough time for that to occur. And me or my individual will not have services. That would be a more effective comment than pointing to the other side and saying they're wrong. I hope that helps you. And somebody's going to bring forward some comments that people had put on the chat, and we'll try to answer them.
Yeah, one person asked about the vendor to licensed provider and whether it was an amendment, a waiver amendment or policy. And it's a complicated question, really. We brought it here because the language is in the amendment. And so absolutely we'll need your comment. The devil's always in the details, and this one is very much so like that. So all of the discussion we had about the vendor turning to licensed provider, the way it happened, that's policy, but that it's happening is the waiver amendment with that language change. So complicated question, complicated answer, but absolutely needs to go. I think that language change needs to be approved, and if we can make it clear what that language change actually means to a person, that's where we have hopefully can get CMS's attention on that particular issue.
But if
There was
it's an amendment, does that mean that, because the amendment things I thought couldn't go into effect until September 1st, but we've been told this will go into effect July 1st. That's why I'm confused.
Yes, I share your confusion, and it is a question we have asked.
Thank you.
Yeah. Stephanie, can you talk a little bit about people's questions about health benefits?
Yeah, there's several questions about health benefits. So, we did hear, I don't know how many of you are aware, but we heard throughout the legislative session comments about, removing the ability to have health benefits, that maybe there'd be a higher wage. We haven't seen anything since some chatter through the legislative session. There's nothing in the manual to indicate that there's really much drastic change. The only thing we identified that's not actually in track changes, which is kind of scary. So the one thing we identified was that they had amended last year's manual to add the extension of if you have someone with health benefits now that don't meet their definition of health benefits, that they had until possibly January, until the open enrollment period. That I didn't see that in that language was removed, in at least what I viewed of the new manual. So we have a question about that. Right now it appears things are going to be remaining the way they were with benefits. We don't really see any drastic changes in the manual to that. My concern as a support broker is that what are these rates going to look like, and how much money is going to be remaining in someone's budget to cover any benefits. So again, advocating, and fighting this way that they're looking at changing the rates, because we're going to be losing a good chunk if they do this of your savings. So that's where that advocacy now has to come in. Next question.
Thank you. Yeah. And I think there's some confusion about the definition of family. I think, Stephanie, you put it in the chat, but if you want to make it clear to everybody who may be not paying attention there, what the definition of family is.
So in the manual, the definition for relative is defined as a natural or adoptive parent, step-parent, grandparent, step-grandparent, child, stepchild, sibling, step-sibling, aunt, uncle, niece, or nephew, who is not also a legal guardian or a legally responsible person. So that it doesn't cover cousins. So, you got some cousins. It doesn't cover cousins. That's pretty much about it. So they changed that definition, went into effect last fall.
Yep.
Stephanie, I'm just going to point out on that one, I feel like it might be worth people to outline in their comments that they've changed the definition of relative in the past. It could certainly be changed again in the future. That change expanded these and put in place more barriers when they did that before. So I think it's important for people to understand that definition could certainly be changed. They could choose to do that. They've done it before.
So there's a question of follow-up about in-laws and how in-laws are treated.
So, we'll have to see if they change the manual. In my opinion, there's nothing in that definition that identifies in-laws. Clearly, they would have to be identified.
The answer that Rhonda gave was, or Christy gave, if your sister marries marries someone, that becomes an in-law, but then that person becomes the aunt or uncle, right? So the fact that it is an in-law relationship then creates them to be an aunt or uncle, and so so you have to. That's the way it was presented. So that the definition does then in fact cover it. It simply doesn't use the words in-law.
Well, it's a brother. If it's your sibling that's getting married, it's a brother-in-law, and it does not identify.
That's true.
So I,
Right,
as
so
a
they
support
would
broker,
split
would
it out. So,
cite that.
well, you
Yeah.
have to split it out when you're rebutting that about when you're discussing it and rebutting it. If it does in fact become an aunt or uncle, then that's covered. So the others you have to split the hairs on that.
Right.
Right. There was a question about a direct hire of a support broker. So I'm not entirely sure what the question was asking. You can
I
hire
see it,
support.
Alicia. I see it.
Okay, go ahead.
It's also one about a nurse. So someone
ahead.
is saying that on the webinar that the support broker nurses did not have to be individual providers. Well, that's true. You could hire me as a nurse as an employee. You could hire a support broker as an employee. But if we are going to not be an employee and what we used to call vendor, we would have to be an individual provider to do that, right? So you can hire somebody as an employee, a support broker or a nurse, but most of those services are vendor. Most people are independent contractors that you're hiring, and then they would have to be the individually licensed by the DDA.
Very good. Stephanie, are you seeing any others we've missed? I don't know the.
There's that very complex question about whether paying family as staff is legal or not. I've tried to research this. I don't know others of you if you have. It seems to me that DDA is they know the CMS rules and guidelines. They believe this is legal. Not to say we shouldn't challenge it. Absolutely we should. It certainly isn't equitable. And that's where I would use the language of where is this equitable? They're doing the same work. Many family members do not live in the same home and get tax, benefits, exemptions. And so why, if, I have someone who has hired his nephew to work for him and he works 40 hours a week, very hard. And he doesn't live with him. So why should he get less pay? So I think when you're writing your comments, you talk about, is this equitable? That, someone is working very hard. It doesn't seem right that they're getting less pay. We continue to look for answers to this. Everything in the CMS language is that they don't have to allow family members to be staff. Each state can choose what that's going to look like. But it doesn't discuss. I have not found any language. Jess, I don't know if you found any language, but I didn't find any language referring to can they pay different wages. We all agree it seems very discriminatory. I think we all agree.
I think a lot of people are looking at the Equal Pay Act, and unfortunately, the familial status of someone is not a protected class under the Equal Pay Act. So if people are looking into that, I will say that there's a lot of people that are doing a little bit of a deeper dive on the protected class of genetics. So you cannot discriminate employment based on someone's genetic profile or genetics. From what I know, there has not been a case under the genetics protected class that would be pursued like what we would need here. But I wouldn't say you could be counted out completely. So, but it would be the first of its kind. Anything that has ever popped up that I've read about for familial discrimination has surrounded nepotism, and that's not necessarily what is happening here. So it's hard to say. It's not impossible, but it's hard to say. I do think that that particular issue is also being looked at under Title II of the ADA from the participants' perspective. So, but that would be an argument that would require some representation in a court.
Yeah.
One of that is something that we are in contact with disability rights about. And so if anybody retains the services of an attorney and gets a legal opinion on that, we'd be open to hearing that for sure. We do not have the funds to employ an attorney at this point to do that. We have talked to attorneys in the past in regard to the compliance with the Self-Direction Act and all those elements and many of the things that we take issue with. And we have found that to be a dead end. So if anybody actually does get a legal opinion on that, we would love to hear it. And we will continue to discuss with disability rights whether there is a discrimination there. But we do know that CMS can do it. The state may need, or the CMS may approve it. We also know that the state may be directed to put it into the waiver amendment differently, such as personal support enhanced, personal support relative. So that I wouldn't be real quick to think that there's a way around it. You need to prepare for it. Like, but at the same time that we all fight back in the ways that we can. Again, if somebody gets an attorney and gets a legal opinion, please share it. We'll continue to work with disability rights, and we will be writing in the comments everything you all are thinking.
I got one more thing I was just going to try and point out to maybe help people understand. There was some questions, I don't know where they fell in the chat because I just lost my place, about the rate tables that were published. There's very little to differentiate between personal supports and personal supports enhanced, particularly for people that are not relatives. And it's noticeable people are picking up on that. And so my comment on that is we are still trying to determine the methodology that they used down to the detail to distinguish that. But in the past, the enhanced portion of personal supports was something they viewed as an acuity factor and the acuity of staff to provide that. And that acuity portion was integrated into the rate development in various ways. Number one being they viewed it under the program support component. And so without that program support being incorporated into a self-directed rate like they're suggesting, they're losing that acuity factor. And then the second way that they kind of addressed this was they look at the BLS code, which is that social and human service assistant. It's the same for personal supports and for personal supports enhanced. And generally, they use the median, the 50th percentile for most of these services. In order to factor in acuity for personal supports enhanced, they have used the 75th percentile of the BLS, which is just an elevated amount. And so I still don't think that you can see that in the wages that were published for non-family of staff. I'm trying to get a good grip on what was said about this ceiling. The only way that that makes sense to me is that in the way our model works, it's not prescriptive, so that this wage isn't just the BLS, it's the max amount, I think is what they're trying to suggest. And so that 75th percentile, until we see the published rates, the $30 to me just is a solid cutoff. I can't seem to figure out what components that actually represents, but that would be like a much more well-rounded answer to why we're not seeing a difference between enhanced and personal supports, if that helps people.
Thanks, Jess. Stephanie, did you have any other questions that
Well, I wanted to make sure everyone saw that the slides, I had to convert them to PDF. So they're in the chat. And then I also put the link to our survey in the chat. We'll also, I'm assuming we should get those on our Facebook page.
Yes, the meeting will be the meeting has been recorded. And with the recording, there'll be the PowerPoint presentation as well. And we are having another meeting tonight at 7. We we'll have any different questions that came up that are particularly pertinent. We'll splice that into, we'll probably have one recording, but we'll add in that other Q&A if it's something different. So
one question.
Yeah.
On slide 17, Christopher had asked about the 60/40, and will there be exceptions to that? And we're proposing that people advocate for that. So if you look at slide 17, where we go through the 60/40, we do think, and in other states it is allowed, that there are exceptions for emergency situations, for respite, things like that. So absolutely, we should be advocating for that in our comments.
Definitely. Maryland's the 60/40 seems to be taken predominantly from Pennsylvania's waiver. And they do have exceptions for respite and for emergency situations. So you can take a look at that yourselves and add that it's not, Maryland sticking their neck out. It's, you're copying, but you left these pieces off. So
and that's been a big shift, I think, that we all saw this year, was there used to be, Maryland was like the leader, and we weren't looking around to see what others were doing. We were proud that we were storming ahead and we were the leaders. And now there's this, from our administration, there's this, well, other states aren't doing this. Why are we, so there's been a massive shift in the philosophy and the thinking of our leaders. And that's what we're seeing that. So.
One thing that a lot of people don't recognize is that our Secretary of the Department of Health, Mina Sheshamini, I'm butcher names, I'm sorry. She was the secretary or the head of Medicare under the Biden administration. So when she came here, she knew clearly what was going to be coming down from the federal government. I mean, it's not like she doesn't understand. And so we have to surmise that many of the changes that we're enduring because she knows what's coming. And she's preparing. I mean, she's not an unenlightened person, having worked in the Biden administration at the Dr. Oz level in the Biden administration. Okay, so I mean, this is horrendous. In all the 36 years that I've been advocating, it has not been this tough, and it has not been this serious. So what you are feeling and thinking is true, but we got to get together. We got to get through it, and we've got to get through it by supporting each other, caring about each other, not tearing each other down, not blaming each other, not going after the providers, but figuring out how we're going to survive this season together. And figuring out how we can my business has taken a hit. If Ethan was alive, he'd be taking a big hit in staffing, and all of my customers are taking a big hit. How do we survive together? We can spend a lot of energy on fighting the legislators. We can spend a lot of energy on trying to give constructive comments to CMS, writing letters to CMS, and saying why we need what we need. And then build those relationships with legislators, so when the pressure starts to valve relieves, we can get these services back and we can get the things back that we're losing. But they're not going to talk to us if we have hurt them in some way, right? We need to build relationships with the people who make the laws. I mean, that's not CMS, but the people that make the laws in our state, and let them know exactly what we're going to need and what's being taken away. So when this pressure valve releases some, we will be able to get some things back, and they will still be willing to work with us. And it is not lost on us just how hard this is for your own home, in your own family, in your own life, because it's happening to every single board member of this state.
Thank you, Patty. I think we're going to get those last two slides up. So close out the meeting. We did the questions as best we could. Thank you again. Please do give us all your brilliant ideas. You can it's not in, join our Facebook page. Oh, here, we're now on Instagram. We have that website and the SDAN. You can either do info@marylandsds.org or the longer ones, self-direction. I think it's in the chat. I'll make sure it gets there again. Next slide. And then at the last slide of the PowerPoint is a whole bunch of reference links, things we've talked about together today: Self-Direction Center, the National Down Syndrome Congress, ARC-US, the BLS chart, the manuals, the amendment homepage, and our the YouTube channels. So all of those are there too. I'm hoping everybody got the handout that wanted it. Again, it will be posted on our website with the video from today, if somehow you missed it. And I think that kind of concludes. Just thank you so much for being here. Oh, Jess, you want to say goodbye?
One more quick thing. I was just going to ask you, do you know if that survey, for that impact survey, is that still open and available for people that didn't get a chance to contribute to that? And
I think so. I think it went out in an email blast 2 days ago. I think the link's still open. And we're happy to take more respondents. More is always better. Yeah, we'll update that if need be. So.
Thank you.
Yep. Thank you. Take care, everyone. Have a good evening.